So the next to go is Dr. Shreesh Kumar. He is the medical superintendent of the CBE branch of Eye Foundation Group of Hospitals. Again, a versatile surgeon to talk on. He is going to speak on nasal pterygium with a 2 diopter with the rule astigmatism and cataract. He would be speaking on combined surgery, and countering him will be Dr. Siddharthan, who is a senior consultant, cornea, cataract and refractive, very capable surgeon with daring skill sets. He would be speaking to us on sequential surgery. So let's start with Dr. Shreesh Kumar.
Good evening. At the outset, I would like to thank Dr. Chitra and Dr. Anagha and the team here at CA for the opportunity. My topic is nasal pterygium with the 2 diopters with the rule astigmatism and cataract. Phaco and pterygium single step procedure. This is the topic I'm debating for. So why combined surgery? So the ultraviolet light exposure is a common etiological factor for both pterygium and cataract. The simultaneous occurrence of which is not uncommon, especially in tropical countries like India. And simultaneous procedure is usually preferred by the patients as it results in rapid visual improvement and lesser number of hospital visits, patient convenience, and lower cost of the surgery. So, pterygium causes astigmatism. Mostly it is withdrawal astigmatism. And the induced astigmatism, it depends on the length, width, depth of pterygium extending onto the cornea. And more the corneal involvement, more is the induced astigmatism. And there is a significant astigmatism which can be seen if the pterygium occupies more than 45% of the distance between limbus and visual axis. This has been published, and pterygium excision, again, it decreases astigmatism. What exactly happens is, so when the pterygium is excised, the horizontal axis, the curvature increases and the vertical curvature decreases. That's what is going to happen. If you look at this case example, this is grade 3 to grade 4 pterygium, and the astigmatism here is around 13.9 diopters. It is very high cylindrical power, and after the pterygium excision, this is 6 weeks post-op, and it is reduced to 2.5 diopters. And this is a comparative chart showing a significant drop in astigmatism. And this is a preoperative astigmatism, and this is 6 weeks post-op astigmatism. And this is a change in the astigmatism. The change is around 11.5 diopters. So these are the cases we should go ahead with the pterygium surgery first, and followed by maybe after 6 weeks or 8 weeks, you can go ahead and do the cataract surgery. However, if you are dealing with a case like this is a grade 1 to grade 2 pterygium, where the astigmatism is around 2 diopters, and after the surgery, this is 6 weeks post-op, it is reduced to 0.4 diopter, 0.6 diopters. So this is the comparative chart. Preoperative 2 diopters, and post-operative it is 0.6 diopters, and the overall the change in astigmatism is around 1.4 diopters. So, as the head of the pterygium, it approaches the apex of the cornea, a tear meniscus forms that develops between the corneal apex and the elevated pterygium, and it causes an apparent flattening of the normal corneal curvature. So, this causes overestimation of IOL power. This is actually the publication from our institute. We did a visual and refractive outcomes following simultaneous vacuum-emulsification and pterygium excision with conjunctival autograft, and where we included almost more than 500 patients between 6 years, between March 2011 to 17. And the phacoemulsification was done through 2.2 to 2.8 millimeter incision, and the autograft was fixed to the base sclera using T-seal glue. And we included patients with grade 1 to 2, and the grading system was actually our own grading system, which was actually published in the Indian Journal of Ophthalmology 2017. And we included patients with the visually significant cataract. All the patients with primary pterygium, both nasal and temporal, and even double head pterygium patients were also included in these cases. And it was grade 1 to 2 diopter, so grade 2 pterygium. First, the pterygium excision, first the cataract extraction, the phacoemulsification was done. And I usually inject air bubble at the end of the procedure so that the AC doesn't collapse during the pterygium excision manipulations. And after the pterygium excision, the thin graft is fashioned and it is placed on the base scleral bed, and it is glued to the surface. And the temporal incision was made in a patient with nasal pterygium, and the superior incision was made in a patient with temporal pterygium. This is our analysis of preoperative and postoperative astigmatism. You can see here the astigmatic data. We found that there was a significant drop in higher astigmatism, that is between 1.25 diopter to 2 diopters. The astigmatism it came down from 49% to almost 19%. And there is a significant increase in the nil astigmatism group. That is from 9.5%, it is increased to 31.5%. That is, there is a significant improvement in the nil astigmatism group, and there is a significant improvement in the higher astigmatism group also following surgery. This is 3 months post-operative data. Coming to the spherical error, 65.5% of our patients had a spherical, no spherical error. Only 35% had a spherical error, of which close to 20% had less than 0.75 diopters. And no other significant complications we had in these groups. And there was a similar study which was actually compared with our study, and Kamya et al., which they included only 60 cases. Ours was a larger study with a larger number of subjects included in this. And we had a mean manifest astigmatism of 0.73 diopters, whereas theirs had an astigmatism of 1 diopter. So it's like the post-operative myopic residual error. It can be anticipated and reduced by slightly undercorrecting the IOL power in patients with the concurrent pterygium to optimize the visual outcome. An important point actually to note before proceeding for a combined procedure is to avoid any intraoperative correction of preoperative cylindrical error. So this is due to the fact that the exact pre-existing astigmatism cannot be distinguished from the astigmatism induced by the pterygia itself. And the susceptible population in tropical countries like ours, it consists largely of daily wage workers without access to insurance, and the loss of days of work on account of surgery amounts to loss of income. So a single procedure results in reduced hospitalization, and it reduces cost, it reduces morbidity, and loss of work days as compared with 2 separate procedures. So a small procedure, small pterygium simultaneous surgery can be preferred, as it may not make a significant difference in the final outcome. Thank you very much.
Very well presented.